Malaria is spread in Africa, Asia, Latin America, South countries of the post-Soviet Union. The disease is caused by protozoa Plasmodium. 4 of them are parasitic in man. Plasmodium vivax, the causative organism of tertian malaria. Plasmodium malaria, the causative agent of quartan malaria. Plasmodium falciparum, the agent of tropical malaria, and Plasmodium ovale, the causative agent of ovale malaria. The source of infection and reservoir of are infected humans and carriers. The main mode is transmissible. Factors of transmission are mosquito anopheles. The time of malaria transmission is summer and fall. 5-6 months in subtropic countries and 6-10 months in the torrid zone. Asexual phase, erythrocytic schizogony. Merozoites invite red blood cells, here they grow and mature into trophozoites, which appear as ring forms. The trophozoites develop into schizones. The infected red blood cells then rupture to release numerous merozoites from the schizone to infect other red cells. Merozoite release results in fever, chills, rigors, and other symptoms of malarial infection. Sexual phase. Some merozoites differentiate into male and female gametocytes, the forms of Plasmodium infective to mosquitoes. These are taken up by a mosquito during another blood meal. These fuse to form an ookinete in the gut lumen of the mosquito. The ookinete invites the stomach wall to form the oocyst. This in turn develops and releases sporozoites which migrate to the salivary gland of the mosquito. This mosquito then goes on to infect another human host. The clinical symptoms are manifested by malarial attack, splenohepatomegaly, anemia. A typical paroxysm includes the cold stage, the hot stage, and the wet stage. The malarial paroxysm begins with the cold stage. The patient is attacked by a shaking chill that cannot be managed by warm cover. The patient complains of headache, nausea, vomiting, pain in the back legs, paleness. The lips, nose, tip, and the fingers become cyanotic and cold. The body temperature rapidly rises to 40-41 within 90-120 minutes. The chill lasts 1-3 hours and is followed by the hot stage fever. The face reddens, the skin becomes dry. The patient removes all covers and his underwear. He becomes restless, complains of thirst, headache, and lumbar pain. Respiration rate increases, tachycardia, dyspnea, and convulsions develop. Consciousness is confused. Nausea, vomiting, and pain in the spleen occur. In 5-8 hours, the body temperature falls critically to subnormal with profuse sweating. The patient is exhausted and drowsy. A paroxysm lasts 8-12 hours. In tropical, 24 hours and more. It usually begins in the morning. Paroxysms recur at regular intervals every other day in tertian malaria in 48 hours and every third day in quartan malaria in 72 hours. After 1-2 paroxysms, the skin and the visible mucosa of many patients turns pale yellow. The spleen and the liver are enlarged. The change in the blood are anemia. In the interparoxysmal periods apyrexia, the patient preserves his working capacity. As the number of paroxysms increases, the patient develops weakness during the afebrile periods. He complains of headache, myalgia, and arthralgia. The skin acquires a grayish hue. Jaundice and hepatosplenomegaly intensify. The number of paroxysms in primary malaria varies from 10 to 12. The body temperature is maximum on the second week of the disease, but during later paroxysm it gradually decreases. The number of parasites in the blood decreases too, and paroxysm cease. In untreated or inadequately treated cases, a short afebrile period is followed by a reinvasion of the bloodstream with the parasites to cause early relapses, during which the temperature reaction acquires the intermittent character specific for each particular type of malaria. Late relapses in vivax avali are followed by an occult period lasting 8-10 months and longer. Late relapses in quartan malaria are due to multiplication of persistent erythrocytic forms of plasmodia. The clinical course of late relapses are absent in falciparum malaria. Common duration of invasion process is 1.5 years, in vivax 2-4 years. Avalis 3-6 years, and in quartan parasite keeps in the blood during several years. In vivax and avali malaria have short incubation 10-21 days and long incubation 6-13 months. Tertian malaria is characterized by prodromal period. Clinical picture is typical. Attack lasts 4-8 hours. Duration of attack is 4-5 weeks. Attacks of vivax malaria usually develop in the morning, while in avali malaria they are more common in the evening. The severest course, a great lesion of erythrocytes, intracapillary multiplication of parasites in internal organs, is characteristic of falciparum malaria. Incubation is 7-14 days. Its fever is irregular and the paroxysms are long, lasting 24-66 hours and longer. The afebrile periods are less pronounced. Chills and sweating are not characteristic because the temperature variation are not very marked. If diagnosed untimely or not treated, falciparum malaria runs a malignant course with cerebral complications, malarial coma, psychosis, algid malaria with severe vascular failure, septic shock, and acute renal failure. Quartan malaria is usually benign. Incubation is 21-40 days. It's characterized by a prolonged course and a great number of relapses over many years. Diagnosis of malaria established on the basis of clinical, epidemiologic, and laboratory findings. The laboratory methods include microscopy of thin and thick blood smears in which plasmodia are detected. Specific diagnosis of malaria is possible with serologic studies. Treatment of malaria patients is aimed at termination of acute paroxysms, prevention of relapses, and elimination of gammons. For radical treatment of tertian and quartan malaria, 4-aminoquinoline derivatives, chloroquine is given for 3 days. Then primaquine is given for 14 days. Falciparum malaria is treated during 5 days. Primaquine is given in keeping in the blood gametocytes for 5 days. Prophylaxis. The complex of anti-malarial measures acts on all 3 factors of the epidemic process: isolation of the source of infection, disruption of routes of infection transmission, disinfection, and chemoprevention.